Ms Carey.
My lady, may I call, please, Professor Laura Shallcross?
Repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the
the truth.
Thank you. Please, please.
Professor Shallcross, thank you for your patience. We got to you as soon as we could, but
Great. Thank you.
Professor, your full name, please.
Laura Jane Francis Shallcross.
I hope you have in front of you your statement ending 613177, dated the 2nd of May of this year.
I do.
I'm going to ask you, Professor, a number of questions about what came to be known as the Vivaldi study. But before I do, can I just introduce you to everyone? I believe you are the Professor of Public Health and Translational Data Science, Director of the Institute of Health Informatics at UCL, and you hold a National Institute for Health and Care Research professorship.
Yes, that's right.
You are trained as a junior doctor.
Yep.
You trained in epidemiology and population health. You have had a number of research published in high-impact journals. I won't name them all. And you have conducted a number of pieces of published research on infection that are relevant to adult social care.
Yes, that's right.
And if anyone wishes to read more about the professor's background, they can do so at paragraphs 3 to 5 of her statement.
Okay.
May I turn, though, please, firstly, to the Vivaldi project. Could you just help us, please? It was set up by you to look at national COVID-19 in care homes. It was funded by the Department of Health and Social Care, is that right?
Yes, that is.
And then in due course subsequently funded by what came to be known as the UK Health Security Agency.
Yes, that's right.
And just as an overview, can you tell us what was the study set up to do?
And so do you mean for the survey initially?
Yeah. Well, there's two parts of the study. There's a survey and a study, but just generally speaking, what was the aim of Vivaldi?
Okay. So very broadly speaking, the aim of Vivaldi was to generate evidence to support the public health response to COVID in care homes. And we did that, as you said, through a survey, which was done very quickly, and through a cohort study, which was done over a 3-year period, ultimately.
Can I put it this way? Was it designed to try and understand why there were such high infection rates in care homes?
Yes, that's right. So it was really recognising that we didn't have the data or the evidence that we needed to understand what was going on. And so a research study was our way of trying to generate that information quickly.
Right. And was it also designed to try and understand what disease control, we called it sometimes IPC, measures could be used to try and mitigate the risk of the disease in care homes?
Yeah, exactly. So, yes.
Now, I think you first got involved when you were approached by Professor Susan Hopkins of PHE, as it then was, on the 8th of May of 2020.
That's right.
Right. Can I ask you, though, at the outset, given that there was involvement by PHE and funding by the Department of Health and UKHSA in due course, do you consider that Vivaldi was nonetheless an independent study of the infection rates and like in care homes?
Yes, absolutely, I do. So we had complete, when I say we, the research team had total control over the design and the analysis of all the data in the study.
So if anyone were to think that because you were being paid by the department and UKHSA, you were therefore singing their tune, would that be right or wrong?
That would be absolutely wrong.
Thank you.
as far as research products are concerned, forgive me because I'm not an academic, so I don't necessarily know that much, but I mean, it's perfectly common for government departments for us to sponsor research that remains independent, even though they may be the purse holder.
That's right. So, for example, the National Institute for Health and Care Research received their funding from the government, but all the research is done independently, and that's a very traditional model that's used for research, yes.
Thank you.
Thank you very much. I think you set out in your statement, Professor, that you were involved in a number of meetings convened by the Health Data Research UK organisation, which brought together a number of researchers and in due course became the study that you set up. Is that right?
So my recall is actually that it was only one meeting for Health Data Research UK. It was more that the individuals who attended that meeting, some of those people then became involved in the SAGE Social Care Working Group.
Thank you very much. And that brings me on to the SAGE Social Care Working Group. I think that from May 2020, the 19th of May 2020 onwards, you began attending the SAGE Social Care Working Group to report on progress.
That's right.
So you're asked to set it up by Professor Hopkins on the 9th of May. From the 19th of May onwards, you're reporting on progress. And I think it's a few months later that you actually start to produce the findings and report those as you go along.
So I would say that that the attendance at the SAGE Social Care Working Group was more as part of that group and being somebody who was involved in research, so partly with the Catch-19 study as well. And our formal reporting was initially to the data debrief group at the Department of Health and Social Care, and there was a very much a requirement that we would report into that group. And as we started doing that, it made sense to do the same into the SAGE Social Care Working Group.
Let me deal with that straight away. I think you say at your paragraph 14, there were two formal mechanisms by which Vivaldi's results were shared. One was with the DHSC data debrief group.
That's right.
Is that correct?
Yes.
Which met on a Thursday. And then you also reported into the SAGE Social Care Working Group, which met on a Friday.
That's right. But we were funded and commissioned via the data debrief group and Pillar 4. So that was really the line management for the study.
Given, though, that you were attending the SAGE meetings on a Friday, how receptive did you find SAGE to the Vivaldi project and its findings in due course?
So I would say once we were fully established and we were generating useful evidence, absolutely very receptive. Everybody was very keen to have as much data as possible to try and inform policy and decision making. I would say at the beginning, when we were setting the study up, and this was particularly as the emergence of the data within NHS Foundry occurred, there was perhaps a little tension about different types of data and which kinds of data might be prioritised. So I think it took a bit of time for the value of what we were doing to be acknowledged, but once we were up and running, absolutely everybody was very receptive to the information we were putting out.
Can I just ask you, please, about some of the things you just said in that last answer, because people may not be familiar with the various data streams and how they're collected and collated. Just tell us, what is the NHS Data Foundry?
So NHS Foundry was set up during the pandemic to support the response. It was managed by NHS England, and it brought together lots of different kinds of data sets, including the testing data, in one location to enable people to conduct research using those data sets to support the pandemic response. And so it was an incredibly valuable source of information for us in the Vivaldi study.
And so when you said there was perhaps a little tension between different types of data, can you just give us a flavour of what that tension was, please?
I think there are well-established systems that are used for public health disease monitoring, and this was a new one. And it was just taking some time for that, for the quality of the data, the opportunities around this data to be made clear to everybody. So I think it was largely around the unfamiliarity. It was just a new thing.
May I ask you this? Did you get any sense that there were people at SAGE or in the DHSC data debrief meetings that didn't want to know how bad the infection rates were in care homes?
I don't think I'm well placed to answer that question. So I work closely with colleagues at the Department of Health and Social Care, and I think that some of the navigation of how to maximise the impact of our work was done by them, not by me. And so I was one step removed from it.
Can I go back to the beginning when Vivaldi was set up? And I think you say that you first attended a SAGE Social Care Working Group meeting on the 19th of May. I'd like to ask you about a paper that came out the week before. And if it helps you, Professor, it's in your tab 14 in your bundle. And could I have up on screen, please, 253601. This is a paper called the Care Homes Analysis from the 12th of May of 2020, so the week before you started attending the meetings. First things first, did you see this paper at the time?
I don't recall seeing this paper at the time.
If we go, please, to page 2 of the paper, we can see at the top there a number of questions that were to be considered by SAGE, some of which seem to impinge on some of the work that Vivaldi was doing potentially. They want to know, does SAGE support the conclusions presented about the characteristics and vulnerability of care homes based on moderate data? Does SAGE agree there's strong confidence there's been a decline in all-cause mortality in care homes by the 12th of May we're talking about? There's recommendations on testing. Does SAGE support the need for further data collection? And does SAGE support the recommendations on future research priorities? And then can I just ask you about the next bit? Are there any proposed next steps? Expand analyses to consider risks in domiciliary care. Were you asked as part of Vivaldi to look at the impact in relation to domiciliary care at all?
No, not at all, no.
Do you have a view, though, given your understanding of the social care sector and your previous involvement in research, as to whether there is, in fact, enough research on the impact of infectious diseases on the domiciliary care side of the care sector?
Purely in relation to the pandemic. So I think that this was a gap that was identified, but it was also recognised how difficult it was to try and address it.
And are you able to give us a flavour of those difficulties?
I think one of the key challenges is around data and identifying the population, and it's hard to do that in care homes, but it's logarithmically harder to do that for domiciliary care, and that's one of the key challenges. But I really had, I recognised it as a problem, but it was not something that I had any involvement in.
Thank you. Can I just turn to page 5, though, which may be something more within your remit of this document, and one can see there that this paper recognised some data gaps, and if one looks at the second bullet point, a data gap was considered to be better linkage between hospital discharge notes and care home readmission would help to assess more accurately the connectedness stroke transmission from hospital and care home settings and vice versa. They would explore options moving forward. Did you have any difficulty when you were conducting the Vivaldi study of linking hospital discharge notes and care home readmissions? It's just as a general question.
I mean, my first question would be, what do these words mean exactly? Because hospital discharge notes, there's no way that we would be able to get access to that information. If they mean routine data about dates that people were discharged from hospitals and dates that people were admitted to care homes, that was something that we could do potentially. But it's quite challenging because of issues around the data. And what I would say is that this particular report preceded my involvement.
Yeah. So do I take it from that when we come on to look at what access to data Vivaldi had, it did not include hospital discharge notes?
No.
So you didn't know patient A left with this medication, these care needs, they've been in and had that treatment done, nothing like that at all?
Sadly, that information does not exist in an accessible format.
Okay. At page 6 of this document, there is reference to large-scale implementation of testing in care homes. And it said there that it's central to preventing and managing outbreaks. Testing can only support reduction of infection rates if coupled with actions to reduce contacts with positive cases and infection control more generally. And then if one looks, there's bullet points, and I'm going to summarise them as recommendations as to how to potentially address that problem. Testing, clearly high-risk care homes that had not reported an outbreak, testing residents and staff, weekly regular testing. Looking at those bullet points there, Professor, do you agree that those recommendations are necessary and that we need to know the answers to those particular outcomes?
So I think broadly speaking, we needed testing in care homes, and some of these points are around trying to prioritise the kinds of testing, recognising that testing capacity was very limited at this point in the pandemic.
Well, we're going to come on to that when we look at some of the results of Vivaldi in a moment. You attended, I think, in due course, 31 of 38 meetings of the social care working group, and presumably you also attended a similar number of the DHSC debrief group. Can I ask you this in relation to DHSC? How helpful did you consider DHSC to be in helping get Vivaldi up and running?
So in terms of the project management support we received, it was excellent. So I really felt that we were able to move very quickly. We were able to problem solve, so to do things at a pace that is not usually possible for research. So examples being ethical approvals will usually take 6 weeks. We were able to get this done in a couple of days. We needed to problem solve around things like accessing PPE, how do we dispose of PPE in care homes that are taking part in the study, and all of these were solved quickly by working in partnership with DHSC. So those elements of the study worked really well.
You say in your statement, though, we were able to get the survey and the cohort study very quickly up and running with strong project management. However, there was a lack of clarity about how the commissioning and funding processes would work for the study. Can you just give us an idea of what you meant there?
Yeah, and I guess I should preface this with it was such an unusual situation to be in. It's not normal that you set up a research study in this way. So we started the work. I was very lucky that UCL were quite willing to be supportive, and there were financial implications that were just put up with by the university. But I think as time wore on, it became clear that this was not going to be a 6-month project. And so we were funded for 12 months in the first instance, and we had to then rebid for funding, which meant writing business cases, which meant, and this was quite, it was time consuming in a sense. We had to justify certain requests for computers or for additional laboratory testing, those kind of things, and it didn't feel seamless. I think when you're working with organisations that are used to interacting with universities, a lot of this is understood. We were working quite often with consultants who'd been brought in from other companies, and so it took up a lot of time. So I think it could have been more streamlined in how we were working together from a commissioning and funding perspective. That was particularly in relation to the cohort study.
All right, well, we're going to come on to the cohort study in a moment, but just standing back for a moment, you said the pace was good at the beginning. Can you give us an idea of how long normally it takes to set up a study and how long it took to set up Vivaldi?
Wow. Normally you would, well, in terms of funding, it could take 12 months. So that's and writing protocols, you would take 2 months, perhaps, to write a protocol. We were writing protocols in 24 hours. Everything was being done at blistering pace because we recognised there was a desperate need for information, and we were trying very hard to support that.
Can I say, please disagree with this if I've got it wrong, but if the bureaucratic nature of perhaps some of the things that need to be gone through was lifted, did that help speed up the process? But in normal time, afraid bureaucracy reigns.
Yes, that's absolutely right. And we've definitely seen the return of bureaucracy post-pandemic, yes.
Can I ask you, please, about your paragraph 9, Professor, and the Vivaldi study itself, and why you say it was necessary to set up this study?
Yes, so I think the striking, when I started doing this work, I'm sure everybody in this room is very aware of the newspaper headlines about deaths in care homes and the tragedies that were unfolding. But what was very clear is that there just wasn't any data to support that. And so if you can't measure infections or measure outbreaks or find out what's happening to people who've been infected, it's very difficult to know how to try and help. And so there was a real need for data and evidence to try and understand what was going on, and as you said earlier, to try and identify the kinds of strategies that might work to try and reduce the spread of infection and outbreaks.
I think up on our screen is a start of your paragraph 9, where you say there are no systems which routinely monitor infections or hospital admissions in individual care home residents or staff. Obviously, there are the notifications to the public health teams when
Yes.
there's an outbreak. But you say establishing a research study was arguably the quickest way to address the gap in evidence on the burden of COVID-19 in staff and residents. All right. So this was needed to be done, otherwise we weren't going to know routes of transmission and how best to potentially what measures might mitigate transmission.
Exactly, and also the ability to respond to the emerging questions.
Can I ask you this? Clearly there was the public health teams that were notified when there was an outbreak of infection. Are you able to explain in what ways the reporting of infections to public health teams was an effective means of managing outbreaks in the first instance, and what difference testing might have made to the managing of outbreaks in care homes?
So the standard way this operates, so pre-COVID, and obviously that was still the system in place at the beginning of the pandemic, is that care homes are requested to notify their local health protection teams when they suspect they have an outbreak. That's usually done by phone call. And then those health protection teams will go in and they will do some testing, and it's usually up to around 5 cases that get tested. So you are always going to be under ascertaining the number of people who have an infection, and obviously when you have a pandemic like COVID, you have a very big proportion of the home that are infected. So that was the setup at the start of the pandemic, and that was how public health agencies were able to try and understand what was going on. But once mass testing was brought in, it gave a much clearer picture of the burden of symptomatic and asymptomatic infection and the extent of those infections and outbreaks.
Can I see if I've understood that correctly? So clearly there is an outbreak, the public health team are notified.
Yeah.
They will test perhaps 5 or 50 residents, let's say.
That's right.
The 5 might test positive, there'll be 5 recorded cases. There could be 45 other people in the home that are positive, and that would not be recorded in the health reporting data.
So I anticipate in that situation, they would assume that many people had been infected, but there wouldn't be any testing data to support that.
But you wouldn't know the precise numbers of the remaining
Yes,
45 people
right.
who were positive and who were negative. All right. Hence why you say there could be significant underreporting.
Yes.
The study, as you have alluded to a moment ago, was split into 2 different work streams, if I can call them that, a survey and the cohort study. And can I look at each in turn? And may we start, please, with the survey? And if it helps you, Professor, I'm at your paragraph 12. Just tell us, what was the survey designed to do and who was it designed to survey?
Yes, so it was designed to answer 2 key questions. So the first was how many people have been infected with COVID, care home staff and residents in wave 1. And the second was to try and get insights into the kinds of strategies that might help to reduce outbreaks and infections in those homes. We did this by surveying care home managers, so that was the population.
I think you say in your statement that the care homes, it was a one-off questionnaire of
That's
care
right.
home managers. We have, I think, at your tab 7, a summary of the project. Can I ask, please, to call up on screen INQ 544939 and go to page 2, please, of the document. But set out there are the aims and objectives of the survey. So by speaking to the care home managers, we're going to collect data on the number of staff and residents in each care home to record care home characteristics. What is meant by the characteristics?
So this is really trying to address those data gaps as quickly as possible. So the first is to say we don't know how many people are in these care homes, so we can't estimate the proportion infected because we don't have the denominator. And the second around characteristics are things like, is it a for-profit care home or a not-for-profit care home? What kinds of disease control measures, IPC measures, are being used in these homes to try and help us understand what seems to be working and what's not working to inform policy on how to limit the spread of infection.
Were there any particular care homes that were included or excluded?
So eligible care homes were those providing care to over 65s or providing dementia care.
And I think in due course, the survey took about 30 minutes to conduct.
That's right.
It was conducted by Ipsos Mori, and there were attempts to contact 8,634 of the eligible care homes. They were analysed, and in due course it came out that there were 5,126 care homes that were included in the study.
That's right.
can you help us? Is that a large number of care homes to survey, mediums? Give us a sense of the scale of that survey.
So for a survey, that's large.
Right.
I think that you may suggest that 56% response rate's not very good, but given the pandemic, given the other pressures on care homes, in my view, that is actually a pretty good response rate. It's a lot of care homes that we were able to collect data on.
The survey itself was conducted over the 26th of May to the 19th of June 2020. Is that right? And it was asking, though, the care home managers about things that had happened before that date range. Have I got that right?
You have got that right. And the purpose of that was because of the question that we'd been set. So we were trying to say how many people have been infected in wave 1, and hence we need to go back in time, recognising that the testing data wasn't in place, so we couldn't get this information easily from other sources, from testing data itself.
We'll come on to the specifics in a minute. But can I go through paragraph 27 of your statement, Professor, which gives a little more detail to how the survey was conducted? You can see the dates there. The early findings were communicated online by the ONS on the 3rd of July. And then if you can see, Professor, the main findings from the survey was an estimate of the proportion of care home residents and staff who tested positive based on the number of cases reported by the care home managers.
That's right.
So this relied in part on any records or memory that they had of the residents and staff that had returned a positive test.
That's right. And the reason we did it like that is because at that time, people were getting tested in all sorts of different locations. And if they were tested in the care home, they might get recorded as a staff member or a resident. But if they went to a mass testing centre outside the care home, we would miss them.
Okay.
And so it was the best way to try and get that comprehensive assessment.
And the survey found there was 10.5% of care home residents who tested positive,
Yes.
and 3.8% of staff who tested positive. But I think you say at the bottom of that paragraph there, it was important to emphasise testing capacity in care homes was very limited during the first wave of the pandemic. So many individuals who were infected with COVID did not undergo PCR testing.
That's right. Yeah.
So did you, can you help us, were the care home managers asked any questions about whether people had the symptoms of COVID, or was it literally, did they test positive or did they not test positive?
So we did ask about those things, but because of the challenges of trying to ascertain what's COVID, what's flu, we were interested in who had tested positive. So, of course, this is an underestimate, but we were trying to get some kind of baseline quickly to give us an idea of the sort of minimum proportion of people who tested positive.
Can I ask you, please, though, about something in the middle of that paragraph where you say that survey responses were linked to individual level PCR test results between the 30th of April and the 13th of June through the National Testing Programme. Can you help us with how the survey responses were linked to the PCR tests?
Yes. So when we, as you can appreciate, we were setting all of these studies up very quickly, and lots of things were changing in the background. So when we started talking about this study, one idea was that we would use the testing, the mass testing data as our outcome, so that we would not be asking care home managers, we would be using the PCR test results. But as things evolved, we realised the testing data wasn't going to be there in time. And so we had a rollout of one-off testing per care home, and so we used that alongside asking the care home managers. But whenever you design a research study, you have to say what your primary outcome is. So our primary outcome was asking the care home managers, and then our secondary way of trying to look at this was looking at the testing data, recognising that it was going to be even more limited than asking care home managers.
Let's come to the findings in your paragraph 30, please, Professor. We'll perhaps have it on screen, and I'd like to take this perhaps a little more slowly than I have been to date. You had data from over 160,000 residents and nearly 250,000 staff members across the 5,126 care homes. Clearly, the proportions of testing positive are the ones we've just looked at. For the reasons you've explained, it would be an underestimate, because it was based on the manager's recall. The number of people infected, of course, were not necessarily tested in the first wave. But there were 53% of care homes that reported outbreaks and 44% 469 care homes reported large outbreaks, which are defined as what, please?
So we define them, and this was an arbitrary definition that we created because there isn't one to the best of my knowledge. So we define this as homes with more than a third of the total number of residents and staff combined testing positive, or those with more than 20 residents and staff combined testing positive. And this was really just to try and get an assessment of the difference between having an outbreak, which at this point I believe was defined as just one positive in the care home, because everybody was making the assumption there were lots of other cases that weren't being tested, versus a large outbreak.
Based on that, you concluded that almost half or all care homes remained vulnerable to COVID in July 2020 because they had not had cases in the first wave. And can you explain, Professor, the significance of that finding, please, and as far as policy might be concerned?
So it's really recognising that, that the problem was going to continue, that all of these care homes, we could potentially just see a repeat of what we saw in wave one if we were not able to instigate effective control measures to try and reduce the spread of infection.
A warning shot then for the waves that then came
Yes.
afterwards. To paragraph 31, please. Clearly, the other aspect of the survey was to look at use of disease control measures, as you call them, to reduce transmission. And the conclusions were that reduced transmission of COVID from staff was associated with adequate sick pay, minimal use of agency staff, and increased staff to bed ratio, so more staff per beds,
Correct.
presumably,
Yes.
and staff cohorting with either infected or uninfected residents.
Yes.
Can you help us with how Vivaldi came to those conclusions, please?
Yes. So we looked in Vivaldi at 4 different outcomes. So we looked at infections in residents, infections in staff, outbreaks and large outbreaks. And then in our questionnaires, we asked about those kinds of measures. So things like, do you use agency staff? Do you never use them? Do you sometimes use them? How often do your staff work across care homes? Very frequently, not very frequently, and so forth. And so we were able to look at the homes reporting in each of those categories and then compare that to the number of infections or the number of outbreaks in those care homes. And then by doing our epidemiological analysis, that gives us a sense of which of those factors seem to be most strongly associated with the risk of infection and outbreaks. And that's how.
So they were the findings that helped reduce the transmission of COVID. Looking at the findings in relation to increased transmission, did Vivaldi find from residents that was associated with an increased number of new admissions to the facility?
Yeah.
Can I just pause there? Does that mean admissions from either the community or hospitals?
Yes. Yeah.
And poor compliance with isolation procedures.
Yes.
So if you didn't have good IPC and there were a large number of admissions, there was a likelihood of increased transmission of COVID in the care home.
That's right. I think the phrasing of the question was about the difficulty in isolating residents, and because obviously with residents with dementia, it can be extremely challenging to try and ask residents to stay in their rooms.
If we just stay with your paragraph 31, you can see there that you reported the results to the Data Debrief Committee on the 11th of June. The social care, 18th, and there's, I think, the 25th, and I will come on to the different meetings themselves in a moment, and the task force, and then to final conclusions in July. Were the findings being refined, if I can put it like that, as the study progressed?
Exactly. So we were accumulating data all the time as the questionnaires were being rolled out across care homes by Ipsos Mori. Data was coming into NHS Foundry, and we were analysing that in real time, and then looking at those data and trying to share them as widely as we could, because we recognised it was our job to try and inform policy making.
Now, you say it's important to note that the Vivaldi survey was a cross-sectional survey which can identify associations between the risk factors for infections and outcomes, but cannot be used to infer causality. Would you help put that into layman's terms, please?
Yes. So what that means is in a cross-sectional study, you are asking questions about your exposures. So what I mean by that are things like, did you use agency staff, how many new admissions you had. So the factors that you are interested in as being potentially important and your outcomes, but you're asking those questions at the same time, which means you don't know if A causes B or if B causes A. Other kinds of studies let you start off by looking at your agency staff, and then you would follow people over time and see what happens, and that gives you a better chance of being able to understand cause and effect.
Right. But we weren't able to do that.
No, not in this kind of study.
Thank you very much. That can come down. I think you said then that obviously you were reporting as the findings emerged. There was a main message on the 11th of June to the data debrief to highlight the risk that staff working across multiple sites posed a risk to residents. On the 18th of June, again, findings suggested that staff working across multiple sites might increase residents' risks of COVID-19, and that staff working across the sites increased the risk of outbreaks. And on the 25th of June, you highlighted that regular use of agency staff was likely to be an important risk factor for infection in residents and staff.
Yes.
And so there we are now at the end of June 2020. Can I just ask you about those meetings? Obviously, you were reporting to the data debrief and then into SAGE as well. Was there any difficulty in you attending the SAGE Care Home Working Group in June 2020 to present those various findings?
So my recall of this was that once we had findings to present, there was an expectation on us that we would report in each week. So not difficulties associated with that I recall.
Okay. And can I just conclude with dealing with the survey by looking at your paragraph 37? And I think, Professor, there's something you want to correct.
Oh, yes.
In paragraph 37.
Yes, so...
We'll pull it up on screen because then I think people will be able to follow and make the correction in their own minds. But you said the survey had a significant impact on policy because you could generate the results quickly, time there was an absence of evidence. The findings suggested staff were more likely to infect residents than vice versa, which informed the decision to focus limited testing capacity for COVID in the first wave on residents rather than staff. The setup of the Social Care Infection Control Fund was supported by two of the recommendations from Vivaldi to minimise COVID transmission, that movement of care workers between sites should cease and that care workers' sick pay should be topped up by the government. That's the nuts and bolts of that paragraph, but help us with the correction that you'd like to make.
Yep, so apologies for this. So in the sentence that begins our preliminary findings, I've accidentally reversed, so it should be... I'll read the whole sentence for clarity. Our preliminary findings suggesting that staff were more likely to infect residents than vice versa informed the decision to focus limited testing capacity for SARS-CoV-2 in the first wave of the pandemic on staff rather than residents. So those two words have been reversed, and apologies for that.
No. So that does tend to suggest that it was staff that were more likely to infect residents than the other way around. Have I got that right?
That's correct. Yeah.
That's not to say that that was an intentional infection by them, quite the opposite, hence why you then made the recommendations that sick pay should be topped up and there needed to be more work done in relation to movement of care workers between sites as a way of helping reduce the risk of transmission of COVID.
Correct.
Now, clearly, you made the findings. Can you help with what was supposed to happen with the findings thereafter and the extent to which you were aware that they were used to inform policy?
So my understanding is that they were very much used to inform policy. We were presenting this data everywhere, all the time, and often at very short notice. And I think the credit to this really goes to my colleague in DHSC, who was really trying extremely hard to make sure that everybody who needed to know about these findings knew about them. But I think we were able to get the information under the noses of the people who were able to make decisions, and that was a very serious priority for us.
Given that on any view there are rather bleak findings coming from the Vivaldi study, did you get any sense that people didn't want to hear the results that Vivaldi was producing?
I don't know that it's not that they didn't want to hear the results. I think that perhaps at the beginning there was were we treading on toes a little. There are organisations whose job it is to provide this kind of data, and perhaps we were filling a gap that maybe it shouldn't have existed. But I think very quickly everybody was very focused on trying to get the data that was required, and so people just wanted data to inform policy.
I'd like to ask you about the Vivaldi findings and the extent to which they impinge on the discharge policy to expedite hospital discharges to care homes. And can I ask you, please, Professor, to look at your paragraph 38? I think, as with most surveys and indeed studies, there are caveats that needed to be applied to this. And I think you say in your statement that the questionnaire that was devised, some of the questions were poorly completed by care home managers. Only 80% of the 5,126 care homes responded to the question about the number of admissions since the 1st of March. I.e., that's the question about admissions from hospital. Is that the question you mean?
Yes, that's right. Yeah.
Right. And only 40% of care home managers answered the question on the number of residents who returned from hospital and the subset with COVID-19. So those perhaps unanswered questions by some of the respondents, in your view, undermine or mean that the Vivaldi findings don't hold water?
So we deliberately didn't report on the latter of those two. So we included new admissions because it was 80% complete, and that seems like a fairly reasonable amount of data. And we also did multiple imputation on those as well, I believe, in our work, which is where you try and account for the missingness in that data. But we didn't use the other data sets because it was such a large proportion of missingness. I strongly felt it was too risky to try and draw conclusions based on that data. And I was thinking about this again, and I think one of the reasons why it was incomplete is because those questions were added in late into the questionnaire.
Thank you. I think it's important to remember in any event, as I think we said before, we were relying on the manager's recall of who had come back into the care home and whether they'd come back from hospital and whether they'd come back from hospital with COVID-19. And of course, at the time, certainly between 1st of March and about the 15th of April in England, testing for COVID-19 was extremely limited.
Yes. I think there's also this risk of reverse causality, which is where the direction is the wrong way round. And if people are very worried and concerned that discharge from hospital into care homes is causing this problem, then they may be more likely to remember it. And so this is a real challenge with asking people to remember what happened.
You make the point at the bottom of your paragraph 39, you were unable to account for other routes of transmission, such as ingress from staff or visitors. Can you help us with what you mean by there and why we need to potentially factor that into the Vivaldi findings?
Yeah, I wonder if the easiest way to think about this is the diagram that's
yes.
in I think it's figure 1 in the CMO technical report.
Could we have up on screen, please? It's your tab 5, Professor, thank you. INQ 203933, and I think it's the one with the all the routes into. Is that the one you're
That's
talking
right.
about?
Yeah,
all right,
exactly.
Just pause a moment while we bring it up on screen. (203933_0298). Thank you. It does appear in the technical report as well, but in fact, I think we've taken it out of a slightly different document. 298 at the bottom. There we are. Thank you very much. This is a schematic showing all the different routes of COVID-19 into care homes. Staff, visiting professionals, visitors of residents, residents leaving the care home for whatever reason, new admissions from the community, residents coming back from hospital, and indeed new admissions from hospital. So there's 7 potential routes by which COVID can enter the care home. And can you help us then by, when you say we were unable to account for the other routes of transmission, why this document helps explain why you couldn't account for those other routes?
Yeah, I think this is a very helpful diagram because what it does is illustrate all the different ways in which infection can get into a care home. But I think it's also important to realise that these changed. This was a dynamic thing. So early in the pandemic, when people could still visit, for example, visitors could potentially bring infection in. Later in the pandemic, that was no longer a mechanism. So this is changing all the time, and it also probably played out differently across different regions in the country. You know, for example, perhaps we saw different patterns with ingress of infection in London early in the pandemic relative to some other parts. So the challenge is that if you really want to understand which of these routes is most important, you need to collect data on all of them. And that requires very good testing across all of these different mechanisms, which we never had. And so in Vivaldi, there are some of these that we were able to say something about, particularly the role of staff, something about people coming in, new admissions, but we didn't collect data on visitors. We didn't collect good data on people coming in from hospital. And so we can't say, we cannot give accurate information on the relative contribution of these different mechanisms.
And so to be able to say, for example, that core staff were the main route of transmission, you would nonetheless need to test all of the others, people on here, to be able to work out that was the main route.
Yes, that's my view.
So essentially you'd have to test everyone.
Yes.
And would a one-off testing regime tell you which was the main route of transmission?
It's going to probably depend at different times in the pandemic. So it's a very difficult question to answer.
So you can say what is a route, but not necessarily what is the main route.
Correct.
Or routes.
Based on data from Vivaldi, yes.
That brings me on, Professor, if I may, to a question that you were asked by the inquiry. And I think, could we have up on screen your paragraph 43? I think you are aware of comments made by Mr. Matthew Hancock in his Module 2 witness statement. And Professor, you should know he's due to give evidence tomorrow. But he said in Module 2, could I have up on screen, please, INQ 613-177_21, in paragraph 43, where we've set out in the middle there what Mr. Hancock said in that statement. He said in his Module 2 statement, and it's in the middle of the page, a widespread concern has been that patients who were discharged from hospitals were the main cause of infections in care homes. While I understand why so many people hold this view, we now know this is not the case. During the summer of 2020, I was made aware of initial evidence showing that movement of staff between care homes was the main source of transmission, and I asked for urgent work to be undertaken to place restrictions on such movements. Now, you were asked to comment on that, Professor, and I think you set out below, and you say it's accurate Vivaldi provided evidence supporting the important role of staff in transmission of infection and the risks associated with movement of staff. The survey did not, for the reasons you've just told us, provide evidence of the relative importance of different modes of transmission. Is that correct?
That's correct. So based on data from Vivaldi, and I'm aware there are obviously other sources of information on this point too, but based on data in Vivaldi, yes, that's correct.
So it's going beyond what can be concluded properly from Vivaldi
Yes.
to say that movement of staff between care homes was the main source of transmission. If I were to substitute a source of transmission, would that be accurate?
Yes.
Right. Thank you. I think you are aware that in due course there was a SAGE consensus statement published. Would you just give me one moment, Professor, to see if I need to go to it? It was not published until the 26th of May of 2022. Can we call up on screen, please? It's your tab 4, if it helps. INQ 215624_2. And in fact, if we just flick over to page 4, you'll see that diagram again. But if we have that in mind, the consensus statement, and go back to page 2, please. The consensus statement found that studies showing that at least some care home outbreaks were caused or partly caused or intensified by discharges from hospital. Do the Vivaldi findings support that or not?
I think Vivaldi, we don't make a major contribution on that, but yes, we are definitely compatible with that statement, yes.
However, based on the very much larger associations between care home size, which is a proxy for all footfall, does that mean the bigger it is, the more people are coming in?
Exactly.
Right. And outbreaks, hospital discharges do not appear to have been the dominant way in which COVID-19 entered care homes. Is Vivaldi able to opine on that or not?
No, but I think this is such a challenging issue. So I think that the conclusions in this are compatible with Vivaldi. For the reasons outlined with this diagram, we have these 7 routes of transmission. There are various studies that are cited in this evidence, and I think it would be fair to say that we don't have a perfect study addressing this question, but based on the data that we do have, it does highlight the important role of transmission from staff.
Can I just look at the Cohort study with you, and perhaps then after that, my lady, it might be a convenient moment for a break. The Cohort study was very different to the survey.
Yes.
Can you tell us how the Cohort study was set up, please? And it's back in your statement, if it helps you, back to paragraph 12 and then various other paragraphs thereafter.
So the Cohort study was set up at the same time as the survey, but it was recognised it was going to take longer. And the initial question we wanted to answer in this was to get a more accurate statement on the proportion of care home staff and residents who'd been infected in wave 1, and to do this with blood testing, with antibody testing. And this is because we recognised that a very big proportion of people were not tested by PCR. And so we set out initially to do this study in around 100 care homes that were owned by Four Seasons Healthcare. And this was serial blood sampling in care home staff and residents to understand who had been infected.
Professor, can I just make sure I understand, and those that are following understand, even though you may not have had a COVID positive test at the time, a blood sample taken later will tell you whether you had the COVID antibodies, and ergo be able to say that even if you didn't have the test, we know that you've had COVID. Have I got that right?
That's exactly right, yes.
So you were looking at the blood sampling to try and not get round the fact that there was no PCR testing, but just to see if we could have different numbers of people now with the COVID-19 antibodies.
Yes, that's right.
And how easy or otherwise was it to obtain samples from people in care homes? Because presumably we need someone to go and take the blood sample.
Yeah, so immensely challenging for lots of reasons, but we were fortunate because we worked very closely with the care sector on this, and were able to find a way to make it work within that setting. So some of the challenges are obviously many people in care homes are cognitively impaired, conditions like dementia, and so informed consent for blood sampling is not straightforward. And so we had to talk to next of kin or nominated consultees, staff members, but we primarily worked with next of kin. And to do that, we were very reliant on staff within those care homes to support that process, because we couldn't go into care homes as a research team because all care homes were locked down at that point.
So you're really reliant on the staff going above and beyond to ring next of kin to say, would you mind if I took the blood sample from your relative, your loved one?
Yeah, exactly.
And are you able to give us a sense of, was there any resistance from the care home staff in the first instance? Secondly, was there any resistance from the next of kin to participating in the study?
So we were really fortunate because right at the beginning of the study, we spoke to the Minister for Social Care and had a meeting with her. I met with her and the Chief Executive of Four Seasons Healthcare. And we talked about the study, we talked about why it was so important, but we also highlighted that this was going to create additional workload for staff. And so we had that organisational buy-in, and they were hugely supportive, and we were able to fund people to act as project managers within their organisations. So actually, we didn't really encounter resistance. I think everybody understood why this was important, and it was very much a shared endeavour. I cannot speak to what it was like being a frontline carer trying to negotiate that. But that was the feedback that we had. And people wanted to know their results, which also helped a lot.
Yeah. Notwithstanding that it added to the burden of the workload
Yes.
on the staff, I think you said there was a further challenge, not just on them, but that you wanted to link the results of the blood testing in the residents to PCR test results where they were available. And you wanted to link it to NHS data sets that were held in the NHS Foundry. How easy or otherwise was it to be able to make those linkages?
So there were two barriers. So the first is if you want to do those linkages, you have to have an identifier, you have to have the NHS number, and lots of care provider organisations don't hold that information. Most of them do now, but pre-pandemic they didn't. And so there were real challenges around how you get accurate identifiers. And then there's the challenge of data linkage, and that really is about putting the data sets in the same location and having the permissions and governance around that. And subsequent changes with the COPI notice that I imagine we'll come on to, it enabled us to find a way around that was much more effective longer term.
Professor, how long do antibodies stay in the blood?
How long do they stay for? It depends. So we could be confident we would have them for sort of 4 to 5 months.
Thank you.
So we're conducting this study, it started in May, I think it was, so it would still capture people who were discharged in March.
Yes.
Yeah. In fact, it would go back almost to the beginning of the 2020.
I think our biggest challenge is that not everybody survived to be available. So again, we have the underestimation problem, and there is variability in the duration of antibodies as well. But
Right. So there's those two caveats to apply to the cohort study.
Yes.
As well. You mentioned their COPI notices, control of patient information, which essentially provides a legal basis for research teams to access data. How valuable was it to have the COPI notices in place to enable the access to that data?
so incredibly valuable. So it changed us from being a study where we could only include care home residents who had consented to blood sampling, which was very challenging for the reasons we've just discussed, to being able to collect data on everybody in those care homes, so all staff and all residents. And so that took us from a study of the sort of order of magnitude of thousands to ultimately we had over 70,000 care home residents and staff in our study. And clearly the power of our analyses and conclusions is much greater if we're able to enrol many more people.
Can we look, please, then, at the key findings from the Vivaldi cohort study? And your paragraph, I think 44 is where it starts, Professor. And it might be useful if we could call it up on screen. It's 613.177_0021. Thank you. The cohort study alongside the survey was to get an accurate estimate of the proportion of surviving staff and residents who've been infected based on the antibodies. And you wanted to track what happened to the resident staff over successive ways. I think you explained that although it started out as 100 care homes, did you say it went to 700?
So ultimately we had, I think it was 346.
340, forgive me, thank you. And then there was the issues with linking it that we've looked at. But if we go on to paragraph 45, the first priority in the cohort study was to estimate the proportion of staff and residents who've been infected. Using the NHS Data Foundry and blood samples, we estimated that 33% of surviving residents and 29% of staff had antibodies showing they'd been infected in the first wave. So quite higher numbers than we looked at in the survey. And would you expect there to be higher numbers based on the antibody cohort testing?
Yes, absolutely.
So that was not a surprise.
It was not. I think we were all surprised at how high it was, bearing in mind these are survivors. But we absolutely expected it to be higher than the PCR testing because we were very aware that that was very limited in the first wave.
Or to put it another way, it shows you how much of an underestimate it was from the survey results.
Yes.
The estimate for residents was approximately threefold higher than in the survey. You say it's not surprising. Shows that many people who were infected in the first wave did not have access to PCR testing. And then help us please really with the next few sentences, Professor. You say, To investigate rates of infection, we compared the PCR positive infection rates in residents and care home staff who had evidence of a previous infection of up to 10 months earlier with those who had not. And what did you find, please?
So the reason we did this, so this was before vaccines were available. One of the key questions was whether people could get COVID more than once. How worried did you need to be if you hadn't had it, essentially? And so what we did is we looked at antibody test results referring to wave 1. So people could be positive or negative. And then we looked among those positives and negatives, what was their chance of getting a new infection. And we found that it was very significantly lower in those who had had a prior infection, highlighting that if you'd had it previously, you had immunity. Obviously, that changed with the emergence of variants, but at that point in time, that was a really key finding because it did provide some reassurance that, there was some protection.
Yeah. So effectively, if you'd had it and survived, you were at lower risk of infection.
Yes.
And therefore help inform policy to look at the places where there wasn't that amount of immunity. They might need more protection, if I can put it like that, or different forms of protection, but to give you an idea of how many people in care homes might nonetheless be protected by the fact they'd had it the first time round.
And I think also importantly, providing some reassurance to people in the care sector about the risk of, if you have had it and survived, then potentially your future risk is diminished.
Now, you mentioned just a moment ago that was before there was the variants as they emerged. Can I ask you, please, about your paragraph 46? Can you help me with what Vivaldi found in relation to, I think it was the alpha variant that emerged in the autumn of 2020?
Yes, so, and this is a really good example of why data and data linkage was so important. So what we were able to show is that as this variant emerged, because of a peculiarity about how the PCR testing worked, we were able to track the emergence of this variant across the southeast of England. And there was good data on how it had spread across in the general population, but no data on the care home population. The hope at the time was because we had a lot of control measures in place, care homes were protected and it wouldn't get in, but we were able to show that the variant had got into care homes and the potential risks associated with that.
And just finally, I think in due course, Vivaldi was asked to look at vaccines against viruses, because there was a concern that COVID vaccines might not provide residents with adequate protection. But what did Vivaldi find when you were able to factor the vaccines in?
So there was a lot of concern because, for example, with influenza vaccine, we know it's less effective in these older age groups. The clinical trials that were done of the vaccines excluded care home residents, so we didn't have any data. We were able to show that the vaccines were actually working very effectively in this population and substantially reducing the risk of infection. And so, again, that provided a lot of early reassurance and also to support the rollout and uptake of vaccination in that population.
Yeah, I think it showed that vaccines did work. They were effective for 3 months after dose 2, but thereafter protection declined.
Yes.
Is that a fair summary?
And we saw that pattern repeatedly because we kept doing these kinds of studies. So we saw after booster vaccinations, within a period of approximately 3 months, you start to see that waning, hence the need for boosters. And so our data was also useful for the Joint Commission on Vaccination and Immunisations when trying to think about the timing and need for boosters in this population.
My lady, a lot of data there, a lot to take in. Would that be a convenient moment?
It is, and
after the
I
break?
it's long I've had quite a tough morning.
Yes,
so,
I appreciate that. I'm sorry.
If you'll forgive us, we'll take a break. I promise you, we will finish your evidence this afternoon. I shall return at 22.
Thank you, my lady.
All rise. Scary.
Thank you, my lady. Professor, you told us earlier this afternoon that the data was shared both with the DHSC debrief group and the social care working group. And during your time at the social care working group meetings, did you see PHE data being referred to during the course of those meetings?
Yes, so from memory, every week we would have a series of presentations. Vivaldi would present, PHE would also present, and they would present on the outbreak data usually.
Right. Okay. Did the Vivaldi survey use any PHE data that you're aware of?
No.
What about the Vivaldi cohort study? Did that rely on any PHE data?
So the cohort study relied very heavily on the testing data.
Yeah.
Testing data was quite complex because there were different routes. They were called pillars. And if from memory, pillar 1 was largely PHE-led data collection, and this included the 5 samples per care home that they used at the beginning. But then there was mass testing, which I believe was pillar 2. And so a lot of the data that we used initially was pillar 2. Over time, we also got access to pillar 1 data. So we will have had some testing data, I think, via PHE. We also had access to data sets like the National Immunisations data set, which I believe is jointly held by NHSE and PHE.
Can I tell you why I asked, Professor? There is some evidence before the inquiry that the quality of PHE data was lacking. Two things. Firstly, whether you experienced that, but secondly, if that is right, whether that in any way affects the Vivaldi cohort study findings. So can I deal with that firstly? Did you, when you were in the meetings, look at the PHE data and come to realise it has some limitations to it? And if so, what were they?
So is this thinking of this as separate to Vivaldi?
Yes,
initially?
separate to Vivaldi.
So I think that the challenge with outbreak data is it's based on reporting of outbreaks, which is largely care homes reporting outbreaks into PHE or UKHSA. And so that is never going to be comprehensive information because it requires somebody to pick up the phone and report data in. This did change during the pandemic to an extent because of the mass testing. But as a mechanism, you are always going to be under-reporting the number of outbreaks and the number of cases if you're relying on a care home to phone in data to a local health protection team.
And was that caveat or limitation, call it what you will, well recognised by the people that were in the Sage Care Home working group?
I would say so. I think almost everybody in that group, a lot of people in that group were had a public health background and so will have had a familiarity with HP Zone, which is the system that's used for that. On some of the other data sets, so on the vaccinations data set, there was never any suggestion that the quality of that data wasn't pretty good.
Right. So to come back to the second part of that question, which was notwithstanding the caveats that have to be applied to the PHE data, do you think that impacts on the validity of the findings of Vivaldi or not in the cohort study?
No, I don't, because the innovative thing we were able to do in the cohort study was to use the testing data which linked individuals in a care home to their care home. So we had their NHS number on the swab, linked to their Care Quality Commission ID, their care home ID, and that gave us a registry of everybody in a care home, and so we knew everybody in the care home, all staff, all residents. And so that's the key difference between adopting that approach to define your population versus having this care homes phoning in about outbreaks.
You told us before the break that perhaps at the beginning there was a feeling that you might be treading on toes a little, to use your phrase, and there were organisations whose job it was to provide the data, and perhaps you were filling a gap that shouldn't have existed. And can I ask you about that answer, please? Which department or organisation was it who should have filled the gaps that Vivaldi stepped into?
So I think in an ideal world, obviously we don't live in an ideal world, we would have great surveillance on care homes. And we don't have great surveillance on care homes. And that's why the situation unfolded in the way that it did and why we didn't have the data that we needed. So I think that Vivaldi came in to fill, or at least partially fill, that gap. And perhaps that's not ideal for a public health agency.
Yeah. So really it's UXA as it now is, or PHE as it then was?
Yes.
Responsibility for surveillance of the care home.
I mean, what I would say is that we did work collaboratively, and that the ability to use that data and work together, I think, was very good throughout the pandemic. But I think, yes, we were filling a gap that ideally wouldn't have existed.
One might have got the sense from your evidence, Professor, that there was a great deal of collaboration during the pandemic, expediency and urgency being at the forefront of the mind. Are you able to comment on whether that same sense of collaboration exists now in 2025?
So I think that we don't have the same impetus. So as you know from the statement, we have a project called the Vivaldi Social Care Project that we've been able to set up. We started working on this from around 2021, and it was really recognising that we need to make sure this kind of situation can't unfold again, and what needs to be in place to prevent that. And I think that we are making great progress towards that, but the priority that it is afforded now versus during the pandemic is different. That's understandable, but I do think that we really do need different organisations to continue working in that same way if we want to make sure we're better prepared for future pandemics and that we have the infrastructure we need to be able to respond in a timely way.
Now, you mentioned the social care project. It's at your paragraph 63 for you and anyone else following. Just help us, though. What is the social care project designed to try and achieve?
So it's really building on what we learnt about what worked in the Vivaldi study. So the reason Vivaldi worked is because it was a partnership between the care sector, academics and policymakers, and because we were able to use routine data. So we really very rapidly recognised that the care sector was under huge pressure. They did not have time to collect data for us. So how can we use routine data to enable better surveillance, but also research, the kinds of research that we need. So we've worked together since 2023 to co-develop this project called Vivaldi Social Care. We've got 700 care homes that have signed up or thereabouts to take part. We've been able to get a new data platform created by NHS England, which allows us to have data on residents and link data on residents. And our ambition is to build on that, to start doing studies to reduce the impact of all kinds of infection, but ensuring that we have that agility to respond to new and emerging threats.
I think you say at the bottom of your paragraph 63 there, demonstrate the value for care providers and policymakers of data by benchmarking rates of infection, any infection, and hospital admission across care homes. Can you help me about that aspect of the Vivaldi Social Care project?
So it's similar to the main Vivaldi, to the Cohort study. So in the Cohort study, I mentioned we created this registry of care home residents, and what we were able to do was then link to data on vaccinations, hospitalisations, deaths, and there's potential to link to other kinds of data sets. So using that same model, we're able to link to data on hospitalisations in care home residents now, post-COVID, and look at hospitalisations for a whole range of causes. So it doesn't give us everything that we would like to know by any stretch, but it starts to give you a sense of what's happening in that population, where the priorities might lie, and a huge potential for surveillance, but also for policy and planning moving forward.
I think you say in your statement you anticipate sharing the first set of results, I think in September 2025, or is that now perhaps a bit later than September?
Yes, we've had some challenges with our data linkage with NHS England, but yes, this year.
Can I go back, please, perhaps to a wider point that you make in your statement, that you say that there is no established culture of research in care homes. Can you help us with what impediment or otherwise that was during the pandemic, and whether, if at all, that has changed now?
So I think the starting point here is research is part of the NHS constitution, so it's expected that this will happen in hospitals. In social care, because social care is not one organisation, it's a much, much bigger challenge. And so there's not the same familiarity with research, and there aren't people who are funded to support the delivery of research. And so it's not reasonable to expect people to add in a huge amount of extra work to their jobs when they're already overstretched to take on the delivery and design of research studies. So we need to overcome that problem by funding people to do research, but also we need to provide the training and capacity building for staff in those care homes. And this really, some of this is not, it's quite simple stuff. Even terms like the word research, this doesn't mean the same thing to everybody. In the NHS, this is understood to an extent, but in social care, some of these words are potentially really intimidating and off-putting. And so there's a whole language and cultural change around this that we need if we want to start delivering the kind of research that we need to see in this setting, and that people in the setting want to do.
if you're able, and it's not an impossible question to answer, who or how do we go about changing that culture? Is it training? Is it there a department or a body that might be able to promote it? Can you help at all with how we might ameliorate that position?
Yeah, so the National Institute for Health and Care Research has a big focus on trying to support more research in social care. I think it's partly about trying to understand what the barriers are and recognising that it is not the same as the NHS. And so this is about partnership working. So we're trying to work towards research that is led by social care. It can't be academics like me marching in and saying this is what we should do. You know, it's the wrong way round. So a lot of it is about understanding the setting, partnership working, and then providing that training, capacity building, and providing the financial resource and incentive so people have their time bought out so they can participate in research studies.
You make the observation in your paragraph 53 that a major barrier to the research was the inability to reliably identify care home residents or staff in the data sets because there is no national registry of residents and staff. Why was that such an impediment?
So if you can't, I think one thing that became really obvious to me in Vivaldi quickly was the power of statistics. So you have to be able to measure things to highlight where issues lie and to be able to get investment and support to address those challenges. And in the care sector, we don't have, or in care homes, we don't have a registry of care home residents or staff. So if you want to look at things like, say you wanted to say how many people aged over 65 have gone into hospital for flu, you can look at our hospital episode statistics data, a routine data set that exists, and you can get the answer to that question. But if you want to ask the same question for care home residents, you can't, because you can't work out which records relate to care home residents. And this just seems like such an important barrier. We don't even have a registry of the population. So it's not that surprising that when a crisis like COVID hits, we're not able to quickly get the answers to the questions about that population and what's happening to be able to inform policy making.
You say we need a new way to develop and maintain a care home registry. Do you have any views about who should maintain that registry and how easily or otherwise it might be maintained?
I think it has to be held as a central resource and as national data infrastructure, because it's not a research study. It's something that would have value across so many different settings. It would be valuable for surveillance. It would be valuable for policy planning, commissioning. It's also valuable for research. So it feels like something that is fairly fundamental. But I think this also speaks to a sort of bigger question about vulnerable populations and how you make the most vulnerable people in society visible. And we have so many challenges around this. So we spoke about the COPI notice, but now the COPI notice is no longer. If we want to do this kind of work in care homes, we have to have approval from the Health Research Authority Confidentiality Advisory Group. To do that, you have to make the case for why you can use data without consent from this population. And the way that's assessed is by demonstrating the population support it. But of course, in a vulnerable population who lack capacity, that is immensely difficult. So what you're actually doing is taking a vulnerable population and then making it really, really difficult to have data on them so that they then become more invisible. And I think there are some real challenges around this about advocating for these kinds of populations.
Maybe questions for DHSC and the UKHSA. Can I just finally ask you this, please, Professor? Obviously, we looked at earlier the diagram showing all the various routes of ingress into care homes, and you've explained, I think, clearly how very difficult it would be to work out which of them was the most dominant route. But do you think there needs to be any research done on any particular one of the number of 7 routes in that would help in the event of a future pandemic?
I think there's a lot of discussion about how we might use point of care testing, so lateral flow devices, these kinds of tests in an effective way. And you could envisage a scenario where these are used more widely in care homes, potentially to test staff, potentially to test residents, or even to test visitors. So I think there is definitely scope to do quite a lot of work in that area. There are some real challenges around it, though, because sometimes if you start detecting infections for which there is no treatment, you can sometimes create more work and more problems. And certainly another thing we learnt in COVID was around the balance of risk and harms of isolating people, quality of life, making sure care homes remain open to visitors and so forth. So I do think we need more work in that area, but I think it needs to be looking at it not just from a health perspective, but also from a social care perspective. So you're considering benefits and harms, but definitely from the resident and the family perspective, not just health.
Professor, those are all the questions I asked before. I know there are some core participant
Yes, and just
questions.
before Mr. Weatherby asks a question, you've described the Vivaldi project and the data. When you talk about the data, are we talking English data?
Yes.
Do you know whether some of the principles you've described apply to the devolved nations, or is that beyond your expertise?
I know a little about these. So the data infrastructure is very different in each of the devolved nations. Certainly in Wales, they have the SAIL data set where a lot of the linkages are already in place. In Scotland, they have different issues. I don't think any of the nations have solved the problem of how you identify care home residents and do all these linkages.
So some of the principles you've expressed would apply around the devolved nations, although they may have slightly different problems or challenges.
I think that's right. I think they would apply to an extent, but in different ways. Yeah.
Thank you. Sorry, Mr. Weatherby.
Not at all. I think, in fact, Professor, you've covered all of the questions that I was going to ask you, but there's one point I just want to clarify, just to make sure that I've understood it. Ms. Carey took you to your paragraph 9, where you said that there are no systems which routinely monitor infections or hospital admissions in individual care home residents or staff. Have I understood your evidence today correctly, that has been addressed, but there are still no ongoing systems to make sure that happens?
So it was addressed during the pandemic.
Yes.
But now, if we wanted to measure cases of influenza, for example, in care home residents, we couldn't do that.
We couldn't.
No.
So is that something that you would invite the inquiry to address in recommendations?
Yes, and that's something that we're trying to address, albeit in a smallish way, in the Vivaldi Social Care Project.
Social Care Project, that's what I'd understood. And just finally on that, would one way of doing it be to make it a regulatory requirement through the CQC?
I think the challenge is it's this difference between having data at care home level versus individual level data.
Yeah.
So there are systems like Capacity Tracker which collect data direct from the care homes on things like the total number of people who've been vaccinated. And that's very helpful. But if you have a pandemic and you want to know how well is the vaccine working,
yes,
ideally you need to be able to track individuals. You get vaccinated, do you get infections? And that's the kind of data that we don't have at the moment because we can't identify those care home residents in routine data.
I see. Thank you very much indeed.
Thank you, Mr. Weatherby. Ms. Jones, over that way.
Thank you, my lady. Professor Shawcross, you've also answered most of what I was going to ask you about today as well, but just to follow on from the points that you made in your evidence about the lack of pre-existing data that you found about care homes, the lack of data linkage and the gaps that you described Vivaldi as filling, including the need, as you see it, for a centralized database of information about those who live and work in care homes. Can you help us at all with what kind of data about those people a centralized database would need to contain in order to be useful for future research and policy making on the experiences and support that people in care homes require?
Yes. So I think at the start, this could be extremely limited. So what we've been doing in the Vivaldi Social Care Project is just the NHS number and the care home ID. And the reason we're doing that is because we simply want to know who is in a care home on a given day. It's just that denominator, because if you know that, then you can link to other routine data sets like hospital admissions, like vaccinations, ideally primary care data. But that's your starting point, and we've approached it in this way because we want to build trust. We don't want to go too fast. We want to demonstrate the value of doing this to the care sector. But beyond that, there is huge scope to pull in all different kinds of data, and particularly thinking about quality of life data, which we know is so important, but is actually really hard to get. there would need to be work to think about how you record that, how you have the capacity to record that across lots of residents. But ideally, you record that annually or every 6 months, and you're able to pull that into your electronic care records, and then that becomes part of your centralised data collection. So I think there is huge scope for us to use routine data to really fill in this gap. And with a lot of the recent advances in data science, particularly ChatGPT, large language models, there are ways that we will be able to start pulling data from care records that doesn't require lots of additional work from care home staff themselves. So yeah, but I think it could be very simple initially.
Thank you. When you refer to quality of life data, can you help us understand precisely what you mean by that?
Yes, so this is not my area, but colleagues of mine have done a lot of work looking at social care related quality of life, so measures that you can use to assess quality of life in care home residents. There have been some projects, there's a study called DHSC that looked at this, I think, in around 60 care homes, and so it's collecting that data and then making modifications to the digital care records so that it gets recorded in those care plans, and then if it's in there, using mechanisms like we're using in Vivaldi social care, you can then pull that into your centralised data collection, and that could be used for a variety of purposes. So there are existing tools to measure that. The challenge is you need a workforce who have time to be able to go and do those measures on residents, and it needs to get recorded in the care records so we can pull it out at the other end.
Thank you. And finally, I know that your experience through Vivaldi was with care homes specifically,
Yeah.
but you of course know and recognise that the care sector is much wider than that. Do you have any insights about the collection of data and how that could usefully be done or centralised in respect of people in other kinds of settings or who receive care at home?
Yeah, so I should apologise also because I'm sure I've referred to social care when I should have said care homes throughout this afternoon. I think some of the principles could apply. I think particularly for domiciliary care, digital care records are used across domiciliary care, and so that is potentially a way into improving our understanding of that sector. How comprehensive the kinds of data that are in those systems, I really don't know. But I do think as a principle, the idea of using routine data as the way in is something that should be explored across domiciliary care as well.
Thank you very much. Thank you.
Thank you, Ms Jones. That completes all the questions we have for you, Professor. Vivaldi's has been an extraordinarily worthwhile project, so thank you for all that you've done and are continuing to do, and thank you also to your university for taking the financial hit at the beginning. I hope they haven't had to continue taking a financial hit, but we're very fortunate the number of universities who are prepared to take the hit at the beginning and allow their academics like you to give us your expertise. So thank you very much indeed.
Thank you.
And thank you for helping the inquiry. It's been a really interesting afternoon. I'm not that good with data sometimes, but you made it seem extremely interesting. Thank you very much. I shall return for 10 o'clock tomorrow.
Come on, Ed.
All rise.